Human sexuality introduction. Sexuality is defined as the constitution and life of an individual relative to characteristics regarding intimacy. It reflects the totality of the person and does not relate exclusively to the sex organs or sexual behaviors. Sexuality is considered a basic human need. However, sexual norms, the definition of sexual dysfunction, and the identification of sexual disorders is largely influenced by the cultural norms and beliefs. What is acceptable in one culture, religion, or time period can be considered taboo and even illegal in another.
So lifespan and development. In reference to human life, lifespan and development, sexual identity before birth is determined by chromosomal factor and genitalia. Male and female infants have been documented touching and exploring their own genitalia and are capable of sexual arousal and orgasm. From 2 to 3 years of age, children know what gender they are and can identify if they are the same or opposite of a parent or other children, because they become acutely aware of anatomical differences of gender. From 4 to 5 years of age, children engage in play that mimics examples of what they see in relationships of adults, such as touching, kissing, and even arguing. They also engage in exploring their own body parts and playing doctor with other children. Non-judgmental talk is needed to talk to children at this age to explain that touching themselves is a private act and to help the child understand that it is never okay for other children to force them to do things, especially older children. Late childhood and pre-adolescence, girls become interested in menstruation and both genders learn about fertility, pregnancy, and birth. Children become self-conscious about their bodies. Interest in the opposite gender increases. From 10 to 12 years of age, children become interested in pubertal changes and begin romantic sexual attraction. Prepubescent boys engage in more genital exhibition than girls, and homosexual play is not uncommon. Once again, the important concern is continued communication and education that forcing or threatening others are never okay. Adolescence is a time of rapid biological changes, and children need to deal with powerful sexual feelings, recognition of love, age-appropriate gender roles, sexually transmitted diseases, and prevention of unwanted pregnancies. Adulthood begins at approximately 20 years of age, and at a basic sexuality level, adults deal with marriage, relationships, and sexual identity.
Gender identity, sexual orientation, and gender dysphoria. Gender identity and sexual orientation are fundamental independent characteristics of an individual's sexual identity. Gender identity refers to a person's innermost concept of self as male, female, or something else, and can be the same or different from one's physical sex. Sexual orientation refers to an enduring pattern of emotional, romantic, and/or sexual attractions to men, women, or both sexes. The study showed existing empirical evidence makes it clear that there is a significant biological contribution to the development of an individual's sexual identity and sexual orientation. Like many of the concepts that will be discussed, gender identity, sexual orientation, gender dysphoria, and transvestism only need intervention and treatment when the individual's life is negatively affected by the condition. Many adolescent and adult people can experience anxiety and depression caused by social prejudice, as well as the inability of the individual to live as their self-perceived gender.
Sexual dysfunction and sexual disorders. When looking at sexuality in the adult, there's a division between sexual dysfunction and sexual disorders. Sexual dysfunction consists of impairment or disturbance in any phase of sexual response, cycle of desire, excitement, orgasm, and resolution. The severity or existence of dysfunction is related to its impact on the life of the client. Most need to have a significant impact and be present for more than 6 months. Sexual dysfunctions include erectile disorder, which is characterized by difficulty in obtaining or maintaining an erection. Primary erectile disorder is when an erection has never been achieved, and secondary is when it has been achieved but is no longer able to be achieved through vaginal or anal intercourse. Female orgasmic disorder is defined by DSM-5 as a marked delay in frequency or absence of orgasm during sexual activity. This is sometimes called anorgasmia. Delayed ejaculation is characterized by a marked delay in ejaculation or marked infrequency or absence of ejaculation during partnered sexual activity. Most commonly, the man can ejaculate from stimulation other than coitus. Premature ejaculation is defined by DSM-5 as a persistent or recurrent ejaculation occurring within 1 minute of beginning partnered sexual activity. Age, duration, excitement stage, novelty of the sexually partner, and frequency of sexual activity need to be considered when doing this diagnosis. Female sexual interest or arousal disorder is characterized by a reduced or absent interest, thoughts, fantasies, or pleasure in sexual activity, regardless of the partner's attempt to initiate. Male hypoactive sexual desire disorder is defined as a persistent or recurrent deficiency or absence of sexual fantasies or desires. Genitopelvic pain penetration disorder can be either lifelong or acquired. The individual experiences considerable difficulty with vaginal intercourse and attempts at penetration due to pain in vagina, around the vaginal opening, around the clitoris, or deep in the pelvis. Fear and anxiety about that pain can also exacerbate the condition by causing the pelvic floor muscles to tighten in anticipation of vaginal penetration. Substance or medication-induced sexual dysfunction. These dysfunctions are related to the use or withdrawal from a medication. Medications include alcohol, amphetamines, cocaine, opioids, sedatives, hypnotics, anxiolytics, antidepressants, antipsychotics, antihypertensives, and others. Sexual dysfunctions are divided into sexual desire disorders, sexual arousal disorders, orgasmic disorders, and sexual pain disorders. Dysfunctions can have biological factors or psychosocial factors.
Sexual desire disorders predisposing characteristics include biological factors include low serum testosterone level, elevated serum prolactin, use of alcohol and cocaine, and use of certain medications including hypertensive, antipsychotics, antidepressants, anticonvulsives, and psycholytics. Psychosocial factors include fear associated with sex, history of sexual abuse, chronic stress, anxiety, depression, and aging, relating concerns. For example, changes in physical appearance. Relationship causes include interpersonal conflicts, extramarital affairs, current physical, mental, or emotional abuse, differing desires and practices from the partner. It is important when looking at arousal disorders to note that the problem may be a discrepancy between the partner's desire and not necessarily a reason to label one partner as pathological. Treatment of hypoactive desire disorders include testosterone and also the medication flibanserin, cognitive behavior and therapy, and relationship therapy to deal with incompatibility and improving communication are also used.
Sexual arousal disorders predisposing characteristics include biological factors that include the decrease in estrogen levels for women, which may prohibit vasocongestion and vaginal lubrication. Various medications such as antihistaminic and anticholinergic medications which decrease sexual arousal in women. Arteriosclerosis, diabetes, temporal lobe epilepsy, multiple sclerosis, and trauma can cause or contribute to male erectile disorder. Psychosocial factors include doubt, guilt, fear, anxiety, shame, conflict, embarrassment, tension, disgust, irritation, resentment, grief, hostility toward a partner, moralistic upbringing, or abuse. These are all cited as possible impediments to female arousal. Malarousal disorder may be related to stress, anxiety, depression, feelings of inadequacy or distrust, a sense of being unloved, or anger towards a partner. These feelings compound due to anxiety over recurrence after the first. Sexual interest and arousal disorders are often treated using sensate focus activities, including touching activities that include non-genital stimulation first, to increase comfort with physical intimacy and reduce anxiety about sexual performance.
Orgasmic disorders. Predisposing characteristics include biological factors for women of hysterectomy, use of SSRIs, depressive disorders, hypothyroidism, and diabetes mellitus. Biological factors for male delayed orgasm include surgery of the genitourinary tract, neurological disorders, diabetes, excessive alcohol use, and medications including opioids, antihypertensives, antidepressants, and antipsychotics. Early ejaculation is commonly caused by psychological factors, substance abuse, and medical conditions such as infections or degenerative neural diseases. Orgasmic disorders are often treated by changing drug regimens, sensate focus therapy, and couples therapy to repair relationships and communication.
Sexual pain disorders. Predisposing characteristics include biological factors for women, including intact hymen, episiotomy scar, infection, ligament injuries, endometriosis, ovarian cysts, and ovarian tumors. In men, biological factors include infection, allergic reaction to spermicides, reaction to vaginal infection, prostate problems, and phimosis, the inability to retract foreskin. Psychosocial factors include previous experience with genitopelvic pain, traumatic sexual experience, and being raised in a belief system with strong association of sex with sin. Education of the client and partner is key in treatment to know exactly what is occurring physically and anatomically. Physiological treatment includes intense exposure to therapy, biofeedback, and CBT, cognitive behavioral therapy. CBT is shown to be as effective as surgical interventions and systematic desensitization.
As a nurse, sexual histories are best obtained using a general outline and a non-directive approach that allows the client to interject information related to feelings or concerns about sexuality and its impact on their life and relationships. Nursing diagnoses focus on sexual dysfunction related to a variety of factors, including trauma, fatigue, anxiety, medication, and relationship problems. We'll be showing you 2 vignettes where a nurse is going to interview a client. We've already told you the dysfunctions, and it's up to you, the listener, to try and guess which dysfunction the person has and if the nurse has appropriately asked questions in order to get the diagnosis. Hi, my name is Deidre Earle, and I'm going to be your nurse today. I was wondering if you could go ahead and give me your name and date of birth, please.
My name is Daniel Donna. I was born on 11/26/1999.
Excellent. And during this interview, would you prefer to be referred to as he, him, or she, her, or some other possibility?
He, him is fine.
Excellent. What brings you here today, Daniel?
Well, me and my partner have been having some troubles in the bedroom lately. I've been seeing her for about 7-8 months now, and it's just hard sometimes, trying to be intimate.
Okay, excellent. And if you could go ahead and let me know, is this your first girlfriend, or have you had other girlfriends in the past?
This is my first, yes.
Okay, and is it a girlfriend? I'm sorry if I asked that and it was inappropriate.
Yes.
Okay, excellent. Thank you. Okay, have you had problems previously, or is this just in the last month or 2 months, or is it kind of in the whole time?
It's been kind of the whole time.
Kind of the whole time?
Kind of the whole
Okay.
time.
Excellent. Were you having troubles with any of your relationships prior to her?
Well, this is my first girlfriend, so.
This is the
Yeah,
first
this is
real
the first
girlfriend? Okay.
Yeah.
Did you ever have like girlfriends or boyfriends or anything else in like elementary school or anything, even if they weren't serious, just kids that you would just hang out with that you kind of called that?
Yeah, I've had a few in middle school.
Okay, excellent. All right. When you were younger, and I know some of these questions are going to get really, really personal, but that's how we're going to figure out exactly what's going on. When you guys are trying to be intimate, do you find that the troubles are happening where she doesn't want you to touch her, or are you finding that things are more with you don't want her to touch you, or is it everybody's into it but things just aren't working?
Yeah, that's exactly it. Everybody's into it, but to be frank, it's just not working with me.
Okay, so are you able to get erect when she's touching you, or is it just nothing is happening at all?
I am able to get erect, but it goes away
Okay,
after a few seconds.
so it's going to go away after a few seconds. Do you ejaculate and it goes away after a few seconds, or you find that you're not able to ejaculate?
I am not able to ejaculate and I'm not able to maintain erection.
Okay, excellent. When you are doing things with yourself, do you do things? Are you able to masturbate? Do you come to ejaculation when you do those things?
To be honest, no, not really. I haven't really been able to keep the erection, so I just sort of say screw it and move on with my life.
Move on with your life, okay? And I can get where you're coming from, where it gets super frustrating. With this frustration, have any of your doctors given you any medications to help? Like, have you seen the psychologist and maybe been so anxious or depressed about this that they've prescribed anything for you?
I have seen my doctor about it. He gave me an anxiolytic to help see if that would fix the problem, but nothing really seems to do the trick for me.
Okay, I've been looking in your record here, Daniel, and I did notice that one of these anxiolytics that I noticed is imipramine. And so looking at that, sometimes that can cause the problem. So sometimes almost like what you're taking to not be anxious can also exacerbate what's going on. So what I'd like to do is that, the doctor's gonna come in, he's gonna talk to you. We're gonna kind of look at that, but what it might mean is it might mean just a change in medication and everything could resolve. That might not necessarily be the case. Have you ever had any problems with infection?
No problems with infection.
Okay, and does your partner have any troubles with infection?
No.
Okay, I would suggest that maybe if you're okay with it, that we do a full workup, do a panel, just to check for any sexually transmitted infections. Would you be okay with that if we did that workup?
Yeah, sure. No
Okay,
problem.
excellent. We really appreciate that, Daniel. So we're gonna do that to start. We're gonna look at your medications to start. And you may have to come back. We're gonna see if things will resolve. And we'll also probably give you a consult to see a psychologist just about ways that you guys can become as a couple a little bit more intimate, not worry about the sex right away. And then maybe things will come it'll be a little bit slower, but maybe there'll be other ways to decrease your anxiety going into it.
All right,
Okay?
perfect. Sounds like a plan.
All right.
Ready.
So if you guess the nursing diagnosis, sexual dysfunction related to erectile dysfunction and substance or medication-induced sexual dysfunction as evidenced by failure to maintain erection during coitus, you got this correct.
Hi, I'm Dex Purcell. I'm going to be your nurse today. And so first we're going to go over just some questions. So my first question is, I know this could be awkward talking to another male. Do you feel comfortable talking with me about this? Okay, and second question, do you feel safe at home?
Yes.
All right, cool. So go ahead and what's your name and date of birth?
Michigan Lawrence, 11/5/1997.
Okay, and what's the gender that you identify as?
Female.
Awesome. And are you married?
No.
Okay. All right, let's get some information. How are your parents? What's their ages?
63 and 52.
Okay. And are they both still alive and well?
Yes.
Awesome. Okay. Any siblings?
Yes, I have like 10 siblings.
Oh my gosh. Very cool. Okay.
They're having a good time.
Okay, any children?
No.
No children. Okay. All right, so what brings you in today?
So I have this new boyfriend, and we've been having, sexual intercourse, and it doesn't matter like the location. Sometimes I'm not getting there with him. It starts off really fun, but it's just like, kind of unpleasing.
Okay. And how long have you been with this boyfriend?
Like a year.
And is this your first boyfriend, or have you had any other intimate relationships?
No, this is my second boyfriend, so not too much experience.
Okay. All right. And so, have you ever had any intercourse before this boyfriend?
Just one previous partner.
Okay. So childhood sex activity.
Nothing crazy. We just, kissing and
Okay.
touching, but not like intercourse.
Okay. And was that with the same gender or opposite?
Opposite.
Do you masturbate?
Yes.
Okay. And is that external, or do you use any type of devices for that, or is it just yourself?
Both.
Okay. And when you do that, can you achieve orgasm at that point?
Yes.
Okay. And with using both of them, is there any pain involved?
No.
Okay. Are you okay with us doing some testing for like infection and stuff like that?
Yes.
Okay. All right. So tell me about your experience with your current boyfriend.
Okay, so everything is good. We talking. Our feelings are there, but then I think he kind of like rushes it, so I don't have enough time to really get into like the mindset of what's going on, I guess.
Okay. So you feel rushed. What other feelings are you experiencing with that?
A little anxiety,
Yeah, that makes sense. That's perfectly natural. Okay. Mishka, are you on any medications currently?
Yes, for my depression.
Okay. And what is that? Do you remember?
No.
Okay, we can look that up later. Okay, are you interested in getting a consult with a psychologist, either for yourself or maybe like a couples therapy?
Yeah, couples therapy.
Okay, so we can do that. Let's see, I'll write that down. Okay, and I'm gonna relay this information to your doctor, and we will go from there, okay?
Okay.
All right, perfect.
Thank you.
So if you guessed nursing diagnosis, sexual dysfunction related to secondary female orgasmic disorder as evidenced by inability to have an orgasm during coitus, you are correct.
Paraphilic disorders are a set of repetitive or preferred sexual fantasies or behaviors that involve non-human objects, suffering or humiliation of a partner, or non-consenting persons. According to DSM-5, it is labeled a disorder when it happens over 6 months and causes significant distress, impairment, or functioning. Individuals who seek treatment tend to have positive outcomes, whereas those who might be arrested for illegal sex acts have poor prognosis due to age of onset, high frequency, lack of guilt, or substance abuse. Most of these disorders are affected by social norms, but a common underlying argument is that the consent of parties involved is a large part in determining whether the disorder is illegal. The following disorders are considered illegal in almost all cultures. Pedophilic disorders. They're manifested as sexual arousal from prepubescent or early prepubescent children equal to or greater than that derived from physically mature persons. Acting on this impulse is illegal as the partner is too young to give consent. The age of the molester is at least 16 years, and he or she is 5 years older than the child. Frauderistic disorder is also usually an illegal act. This is the recurrent and intense sexual arousal involving rubbing up against a non-consenting person, usually in a public space, such as crowded transportation, where the rush of the crowd allows him to push against a woman and escape detection. This is almost exclusively a male disorder. Other paraphilic disorders can manifest in ways that range from culturally acceptable to illegal. It is important to distinguish sexual sadism disorder from consensual bondage and discipline, dominance and submission, sadism and masochism or BDSM practices. These include exhibitionist disorder, which is recurrent and intense sexual arousal from exposure of one's genitals to others. Fetishistic disorder, the recurrent and intense sexual arousal from inanimate objects or non-genital body parts. Examples of fetish objects include shoes, gloves, stockings, which are used during masturbation or incorporated into a sex act. Sexual masochism disorder is the recurrent or intense act of being humiliated, beaten, bound, or otherwise made to suffer. These can manifest as fantasies, be performed alone, performed with a partner. Some of these activities involve oxygen deprivation and have resulted in death. Sexual sadism disorder is defined by DSM-5 as the recurrent or intense sexual arousal from the physical or psychological suffering of another individual. These may be fantasized, performed with a willing participant, or a non-consenting partner. Activities with non-consenting individuals are usually terminated by legal prosecution. Voyeuristic disorder involves recurrent or intense sexual arousal involving the act of observing an unsuspecting individual who is naked, disrobing, or engaging in sexual activity.